Hey, dear great surgeon. Today we're gonna talk about a very important yet hard topic for non-orthopedics, the orthopedics, the almighty orthopedics. It's very important in every exam and overlapping with many chapters from anatomy, trauma, preoperative and postoperative, even with pediatrics. So it's a very important topic in the exam, yet very confusing for many. So we will try together in this voice shot to make it simple as much as possible to make it a more happy experience. So let's go through orthopedics together, dearest friends.
Osteomalacia is low calcium with raised alkaline phosphatase. Again, osteomalacia with low calcium and phosphate and raised alkaline phosphatase. The low calcium and phosphate in the exam with raised alkaline phosphatase point toward osteomalacia. In the exam, when you find the calcium, phosphate, and alkaline phosphatase all are normal range, you are talking about osteoporosis. Osteomalacia, the calcium and phosphate are low, while in osteoporosis, the calcium and phosphate will be normal. And the alkaline phosphatase is normal in osteoporosis and raised in osteomalacia. The osteomalacia is demineralization of the bone, while osteoporosis is reduction of bone mineral density. Rickets is like the osteomalacia for the children. Its serum calcium or phosphate is low due to deficiency of vitamin D in children, while osteomalacia in adult is the same, serum calcium is low. While in osteoporosis there is no biochemical change in blood. The calcium and phosphate are normal. We have said it 3 times, so never forget it. In syringomyelia, you will find the patient have selectively affected the spinothalamic tract. Syringomyelia is a disorder in which a cystic cavity forms within the spinal cord. The commonest variant is the Arnold-Chiari malformation, in which the cavity connects with a congenital malformation affecting the cerebellum. The acquired form may occur as a result of previous meningitis or surgery or even tumors. Many neurological manifestations have been reported, although the classical variety spares the dorsal column and the medial lemniscus and affecting only spinothalamic tract, with syringomyelia over the brown cord or any other disease. Osteomyelitis would tend to present with back pain and fever in addition to neurological signs, and the epidural hematoma is large enough to produce neurological impairment. We usually have motor system as well in addition to selective sensory loss, and history is usually shorter. So, syringomyelia must be in your mind in the exam. A very famous case scenario about intravenous drug abuser with back pain and pyrexia. This will lead to a high suspicion for osteomyelitis. The most likely organism is the Staph aureus, and the cervical spine is the most common region to be affected because remember, TB tend to affect the thoracic spine. In other cases of osteomyelitis, the lumbar spine is affected. Brown cord syndrome is a hemisection of a spinal cord. It may result from a stab injury or lateral vertebral fracture and will result in ipsilateral paralysis, the pyramidal tract, and also loss of proprioception and fine discrimination, the dorsal column, where the pain and temperature sensation are lost on the contralateral side. So when you find a patient who have lost his pain and temperature sensation on the contralateral side with loss of motor function on his same side, this was high suspicion for Brown cord syndrome. This is because the fibers of the spinothalamic tract have been decussated below the level of the cord transection. Remember that avascular necrosis is a cellular death of bone component due to interruption of blood supply, causing bone destruction. Main joint affected are the hip, scaphoid, lunate, and talus. Again, main joint affected are hip, scaphoid, lunate, and talus. It's not the same as non-union. The fractures are usually united. The radiological evidence is slow to appear. Don't wait for them in the X-ray. And if you insist to see him in radiological evidence, you can use MRI. Vascular ingress in the affected bone may occur. However, many joints will develop secondary osteoarthritis. The causes are pancreatitis, lupus, alcohol, steroid trauma, idiopathic infection, Caisson disease, and there is a case about Caisson disease and avascular necrosis, by the way, in the records, radiation, amyloid, and Gaucher and sickle anemia disease. The presentation would usually be pain of the avascular necrosis, and often despite appearance fracture union. You will find the fracture apparently fused, but will cause severe pain. Investigation MRI will show changes earlier than plain film, and the treatment, the fracture at high risk site anticipation is a key. Early accurate reduction is essential, and non-weight bearing may help to facilitate the vascular regeneration. Joint replacement may be necessary or even preferred option, especially in hip and elderly patient. Remember, in avascular necrosis, the radiolucency and subchondral collapse are related changes. The earliest changes radiologically is that the affected area appearing more radio-opaque due to hyperemia and resorption of the neighboring area. May be diagnosed earlier using MRI. A combination of crash injury, limb swelling, and inability to move the digits should raise high suspicion of compartment syndrome, especially after trauma, that will require fasciotomy. Compartment syndrome will require fasciotomy, and paralysis is very late sign, and never wait until you know feeling pulse. It's a late sign as well. There are many causes of irritable hip joint for the age of 10 to 14 year age group, and many of these causes, both hip pain or knee pain, are found. The transient synovitis of the hip is the commonest disorder, but doesn't typically last for 3 months. And osteosarcoma wouldn't usually present with apparent limb shortening unless the pathological fracture had occurred, while a slipped upper femoral epiphysis, the SCAFE, had caused a similar presentation, although it typically presents later and with different pain characters. The birth disease is idiopathic avascular necrosis of the femoral epiphysis of the femoral head, with impaired blood supply of the femoral head, causing a bone infarction. New vessels develop and ossification occur. The bone either heals or subchondral fracture occur. The clinical features: male patient at age between 2 to 12 years, limp, hip pain, and bilateral in 20%. Salter-Harris fracture is a fracture that involves the epithelial plate or gross plate of the bone, specifically the zone of provisional calcification. It thus forms a child bone fracture. It's a common injury in children, occurring in about 15% of the childhood long bone fracture. And a very common question about the similar radiological finding in the types of Salter-Harris classification, which is type 1 and type 5. Remember, the surgical neck fracture of the humerus doesn't require surgical repair. The surgical neck fracture of the humerus doesn't require surgical repair. It's for conservative repair. The impacted fracture of the surgical neck are stable injuries and usually heal without complication. It's rare to need a surgery. and it's important to start physiotherapy early. In ruptured posterior cruciate ligament, the tibia lies back on the femur and can be drawn forward during a paradoxical draw test. Dennis-Weber classification is commonly used based on the level of the fibula fracture in relation to the syndesmosis. The more proximal, the greater the risk of syndesmotic injury and therefore fracture instability. We have A, P, C types. 3 types, A, P, C. Type A Weber classification is fracture below the level of the syndesmosis, which is merely stable, while type B fracture at the level of the syndesmosis, level of the tibial plafond. Type C fracture is above the level of the syndesmosis and indicates Mesonef fracture as like a proximal fibula fracture, which can be associated with ankle instability. So beware of the high fibula fracture. It might be ankle fracture. So the Weber classification is based purely on the lateral side. All injuries can include medial or posterior bony ligament injury, which also decays the fracture stability. Bimallear, trimallear, or more stability are more unstable. The bimallear and trimallear are unstable. Management of the ankle fracture according to Weber classification. In type A, unimallear type A, Weber fracture by definition is stable, therefore can be mobilized fully weight bearing in an ankle boot. In type C Weber fracture, the fracture tends to include syndesmotic disruption and usually bimallear, either bony or ligamentous. They are therefore unstable and usually require operative fixation. In addition to fracture fixation, the syndesmosis usually require reconstruction and augmentation with screws to restore the joint integrity and function. In type B fracture of Weber, the fractures are greatly variable. They can be a part of trimallear injury and therefore extremely unstable and require fixation. And alternatively, a unimallear Weber B classification can be stable injury and therefore mobilized immediately in ankle boot. So, defining the stability can be challenging and often involve stress radiography, or a trial of mobilization of repeat radiographs. So, defining the stability is subject of much ongoing research. However, treating undisplaced ankle fracture in a blow knee plaster and the non-weight bearing for 6 weeks is still widely practiced and a safe approach for type B Weber fracture. Take care. You have to monitor the patient because displacement might occur in the first 6 weeks. Giant cell tumors on X-ray have a soap bubble appearance. They present as pain or pathological fracture. They commonly metastasize to the lung. Hypocalcemia and low urinary calcium are biochemical features of osteomalacia because we agreed on osteoporosis are normal biochemical electrolytes. So unfortunately, surgeons do need to look on some blood tests. Ewing sarcoma is most common in male between 10 and 20 years. It can occur in girl and a lytic lesion with laminated or onion-type preosteal reaction is classical finding on X-ray. The onion with the Ewing sarcoma. Onion, Ewing sarcoma in X-ray. So most patients will present with metastatic disease within a 5-year prognosis between 5 to 10%. Although scaphoid fracture is rare in children, it requires a high suspicion of the doctor and initial clinical examination with repeated X-ray might be required due to the suspicion of scaphoid fracture. The menisci have no nerve, no blood supply. The menisci have no nerve nor blood supply and thus heal poorly. And established tear will associate symptom are best management with arthroscopic meniscotomy with the arthroscope. So, meniscal tear can't be managed conservatively and always will require arthroscopic meniscotomy. And the medial meniscus is most often to be affected, and true locking of the knee might occur, but can't be managed conservatively at all. It's not advised because it has no nerve, no blood supply. Take care. Osteoporosis, not osteoporosis. Osteoporosis is autosomal recessive condition, commonest in young adult, present with symptoms like anemia, thrombocytopenia due to decreased narrow space, radiologically reveal a lack of differentiation between the cortex and the medulla. You will see a marble bone. These bones are very dense and brittle. Osteogenic imperfecta is caused by defective osteoid formation due to congenital inability to produce adequate intracellular substance like osteoid, collagen, and dentin. There is a failure of maturation of the collagen in all connective tissue, and radiology may show translucent bone. See here, translucent bone, while in osteopetrosis was dense and brittle. In osteogenesis imperfecta will be translucent. In osteopetrosis will be dense and brittle. In osteogenesis imperfecta, radiology will show translucent bone. Multiple fracture, particularly of the long bone and Wormanian bone, with irregular patches of suffocation and the trifoid pelvis. So poor child. Rickets is a child form of osteomalacia in adult. Rickets is a child form of osteomalacia. It's due to the failure of osteoid to ossify due to vitamin D deficiency. Symptoms will start about the age of 1 year. The child is small for the age, and there is a history of failure to thrive. Bone deformities include bowing of the femur and the tibia. The large head will be posing, and deformity of the chest, with thickening of the costochondral junction, ricketary rosaries, and the transverse sulcus of the chest caused by the pull of the diaphragm, Harrison sulcus. X-ray will show widening and cupping of the epiphysis of the long bone, most readily apparent on the wrist. Hemiarthroplasty is offered to older, less mobile individuals compared to the fracture reduction and fixation in younger patients. Take care. I know many of you is not orthopedic, so hemiarthroplasty and total hip may confuse you. In hemiarthroplasty involve replacing the femoral head with a prosthesis, but the total hip arthroplasty include replacement of both the femoral head and the acetabulum with the prosthesis. In total hip, replacement of both the femoral head and the acetabulum. The total hip replacement when you are expecting more range of movement and you want more range of movement, while in hemiarthroplasty when you are not expecting the patient to be totally mobile. Inglesi fracture, radial shaft fracture with associated dislocation of the distal radioulnar joint. It's due to a direct blow. So remember, Montegia is dislocation of the proximal radioulnar joint associated with ulnar fracture due to fall on outstretched hand and forced pronation, and needs prompt diagnosis to avoid disability. Montegia ulnar, MU, while GR is Gliese fracture. MU, Montegia ulnar, Gliese, GR, Gliese radius. So Montegia ulnar, Gliese radius. Montegia ulnar, Gliese radius. And remember that Smith fracture is the reverse of Colles fracture. Smith fracture, there is a volar angulation of the distal radius, caused by falling backward onto the palm of outstretched hand or falling with wrist flexed. Colles fracture is fall onto extended outstretched hand, unlike Smith fracture, which is falling on flexed wrist. So Colles fracture is fallen outstretched hand extended. Colles fracture, there is a dorsal displacement. In Smith fracture, volar angulation and volar displacement of the radial fracture. Again and again and again. Osteomalacia, Malaysia low. Malaysia low. Calcium low phosphate, raised alkaline phosphatase. Malaysia low. Calcium low phosphate, raised alkaline phosphatase. Osteomalacia. Common question about falling in outstretched hand with pain and no sign in X-ray. You have to be suspicious for scaphoid fracture. So you can tell the patient to go home with futura splint and the fracture clinic appointment for repetitive examination and repetitive X-ray. Remember, scaphoid might occur with avascular necrosis. Any normal human being will hear a garden is related for a place where you enjoy your quality time. But for surgeon, it's where neck or femur classification be. Garden classification. Talibus equinovarus. Its feature is equinus of the hind foot and adduction of the varus of the midfoot and high arch. Again, equinus of the hind foot, adduction and varus of the midfoot and high arch. Most of the case developing countries. Incidence from 1 to 1,000. 1 per each 1,000 life, we will have a case of Talibus equinovarus. It's more common in male and bilateral in 50% of the cases. There is a strong familial link to Talibus equinovarus. May be associated with other developmental disorder such as Down syndrome. The key anatomical deformities of the Talibus equinovarus: adducted inverted calcaneus, wedge-shaped distal calcaneum, severe tibio-talar plantar flexion, medial talar neck inclination, displacement of navicular bone, wedge-shaped head of talus, displacement of the cuboid. The management of the Talibus equinovarus. First, we will try to do a conservative treatment. The Busetti method is best described and give comparable result to surgery. It consists of serial casting to mold the foot like a mold in several casting as a conservative management to correct shape. Following the casting, around 90% will require Achilles tenotomy. This is followed by phase of walking braces to maintain the correction. And if we have surgical correction is reserved, it will be for those who fail to reopen conservative message. The procedure involves multiple tenotomy and lengthening procedure. In the patient who fail to respond surgically, a laser roof frame might be a good result, a good chance. So first cast, then multiple tenotomy, and then laser roof. Buccal fracture. Buccal fracture occurs when the bone buckles or slightly crushes on itself. The bone stresses on itself. The most common type is the buccal fracture in children. It occurs in the forearm. The buccal fracture in children can heal in a plaster cast for 2 to 3 weeks, from 2 to 3 weeks, and almost completely heal in 4 weeks only, because it's more common in children. Green stick fracture is a common childhood injury, and in the X-ray, it's defined as unilateral cortical disruption. You will see only one side of the bone cortex is disrupted, while the other is intact. If both cortici are disrupted, this is not a green stick anymore, it's a complete fracture. The buccal fracture will show periosteal hematoma formation in the X-ray. Take care, malunion would be unusual with femoral neck fracture because it's a weight-bearing joint, and if the fracture is not united, then doesn't heal. If the fracture of neck femur is not united, doesn't heal at all. So either heal or doesn't heal. There is no malunion. It's for this reason the most femoral neck fracture are fixed, because avascular necrosis is a well-recognized complication and total hip replacement or hemiarthroplasty usually considered in the elderly. Again, Salter-Harris classification system of the epiphyseal injury is very important and common question in the exam. We have 5 types: type 1, 2, 3, 4, and 5. Type 1 like type 5. Type 1 is through the gross plate itself, where it's slipped the epiphysis, while type 5 fracture is compression injury. And in case you forgot, remember from its name, Salter, the type S1, A2, L3, T4, R5. The letters of Salter-Harris itself, the Salter, can be your mnemonic in the exam. How is that? Because Salter, S, type 1, S, slipped only slipped the epiphysis. There is no fracture, but slipped the epiphysis. Type 2 will be from the word Salter, so second letter will be A. So it's above. Above is the metaphysis. So the fracture will be involving only the metaphysis. Type 3 is L, low, lower. The epiphysis is lower. Type 4 through both of them. T through. So A above, L low, T through. In type 4, both the epiphysis and metaphysis both are fractured. And type 5 is like type 1, but it's rammed. It's not slip. It's a fracture compression injury. The odontoid process, also the dens or odontoid bag, is a protuberance or a process or projection of the axis, the second cervical vertebra. It exhibits a slight constriction on the neck, where it joins the main body of the vertebra. Remember that air palsy from the upper trunk injury. Air palsy from the upper trunk injury. Remember, clump, claw, low. Clump, claw, low. Clump, claw, low. Clump's palsy forms a claw hand due to lower trunk injury. Fat embolism is associated with major trauma and liposuction and fractures. It may manifest as increasing dyspnea, hypotension, falling in oxygen saturation, and PO2 and PCO2 will be low. It's commonly associated with skin rash, like typical TK rash in the chest. So take care and be aware. This rash, those spots, are not allergy post-operative, are not allergy post-traumatic. They must be fat embolism to be excluded first. Remember, the second cervical vertebrae. In MRCS Part A, the vertebrae details are not required as much as Part B. To be safe and don't feel that it's a big load on you. So, regarding the second cervical vertebrae, the axis, it bears a conical projection, the dens, which is the ondoid peg or the ondoid process, on the upper surface of its body. The odontoid peg articulates with the back of the anterior arch of the atlas, and it held in position by the transverse ligament of the atlas. The median allantoaxial joint is where the odontoid peg articulates with the back of the anterior arch of the atlas. This is a synovial pivot joint between the odontoid peg, the odontoid process, and a ring formed by the anterior arch of the transverse ligament, the cruciform ligament of the atlas. Between the two is relatively a large bursa. Between the atlas and the axis, the atlantoaxial joint, between the two, there is a relatively large bursa. In addition to the joint, certain accessory ligaments the tectorial membrane and cruciform ligament, and the apical and alar ligament. Tectorial membrane, cruciform ligament, apical and alar ligament. They connect the axis to the occiput by passing the atlas. Remember, the spleen removes the intracytoplasmic inclusions such as Howell-Jolly bodies and Heinz bodies and siderotic granules. All of these are increased after splenectomy because the spleen was removing the Howell-Jolly bodies, Heinz bodies, and siderotic granule. In diabetic foot, you have to look for the bone and the vessels and the skin. The skin is visible with your eyes. There is no skin biopsy in diabetic foot. And you have never to be missing the X-ray in diabetic foot or the duplex to check the vascularity because they have peripheral neuropathy and peripheral vasculopathy. So the microangiopathy and neuropathy must be not missed in diabetic foot patient, and you have to do a duplex, arterial duplex, and X-ray to check the integrity of the bone and if there is osteomyelitis or not. MRI gives aerial signs for osteomyelitis, but believe me, in diabetic patient, X-ray will be sufficient from practice because he is mostly to be a negligent patient, unfortunately. In diabetic foot, you do skin debridement, not a skin biopsy. Please take care. There is a big difference between infection and gangrene in diabetes. In diabetic patient, if he had a gangrenous leg, we have two types of gangrene, dry and wet. If we have a dry gangrene, please do a duplex, and if there is a need for angioplasty, do it before debridement of the gangrene, of the dry gangrene. While if we have infection, so we have to cut off this infection first. For your own practice, whenever you face an ulcer or chronic ulcer or even a recent wound, try to use the healing promoters. It makes a huge difference in the patient quality of life and the duration and the hospital stay. Whatever wound you are dealing with, try to know about the healing promoters, which fastens the healing of the ulcers during your practice. It will give you a good result in your practice. Of course, when you are talking about the healing promoters, not to miss the incidence of the cause, never to miss the arterial supply and the condition of the bone and the quality of the skin. The healing promoter doesn't bring the dead alive again, so you have to do debridement first. Calcific tendinitis. It's a common disorder of unknown etiology, which result in an acutely painful shoulder. In the majority of the patient, there is no history of trauma. The deposition of the calcium within the supraspinatus tendon may be part of degenerative process. A clinical feature of this condition includes sudden onset of pain with no apparent precipitating cause. You ask, have you been hit? Have you been having an accident? He said no. So on examination of the shoulder, there is a tender anterolateral with some restriction of both active and passive movement with no apparent precipitating cause. External rotation of the shoulder is however possible in the calcific tendinitis. This distinguishes it from the frozen shoulder. Rupture of Achilles tendon is more common in patients over the age of 40. This is probably because the tendon is degenerated. The rupture usually occurs when the patient is involved in unaccustomed activity such as running or jumping. He is above 40. Well, sudden contraction of the gastrocnemius and soleus muscle is resisted by the body weight, leading to the rupture of the tendon. So, if you want to be 40 and keep your tendon healthy, please run from now. Soon after the tear, a gap can be felt about 5 cm above the insertion of the tendon, but there is no hematoma in the lower leg calf. The patient is unstable to tiptoe and plantar flexion of the ankle The patient is unstable to tiptoe and the plantar friction. During your study, if you have found some questions away of the scope of the MRCS or past test, just make sure you have understood the ideas you face in MRCS and past test. MRCS and past test questions fulfilling the whole curriculum and ideas you want either for your exam or away from the scope of the exam. So read the explanations well and understand them well, and just with revision you will build up your knowledge. So don't worry, you are doing great. You are true heroes and champs. God be with all of you. So happy to have been with you. The median nerve starts in the arm, lateral to the brachial artery, then anterior, then medial after the cubital fossa. So the cubital fossa structure from outside to inside, from superficial to deep. The very superficial is tibial nerve, then the popliteal vein, and the deepest structure in the popliteal fossa will be the popliteal artery. That's why it's hard to be felt during palpation of the popliteal artery. So the ideal incision for submandibular gland incision will be transverse oriented incision 4 cm below the mandible. It's called a Hilton technique, by the way. So the IVC at T8, the esophagus at T10, and the aorta at T12. Those are the entrance of aorta, esophagus, and IVC through the diaphragm from the thoracic cavity to the intra-abdominal cavity. The vertebral level of the abdominal aorta branches is very important. From the very common asked questions in the exam, the level of the celiac vessel or the celiac trunk at T12, the superior mesenteric artery at L1, and inferior mesenteric artery at L3. He might ask about those directly or indirectly. He will ask you about a branch from the superior mesenteric artery and ask you, the ileocolic is a branch from a major vessel which originate from? He asking about the ileocolic artery, which is branch from the superior mesenteric artery, which is L1. Again, the nerves that pass through the superior orbital fissure. Live frankly to see absolutely no insult. Live frankly to see absolutely no insult. Lacrimal nerve, frontal nerve, trochlear nerve, superior division of the oculomotor and abducens and nasociliary and inferior division of the oculomotor nerve. The trick in the superior orbital fissure is that the ophthalmic nerve doesn't pass through the superior orbital fissure but the oculomotor nerve. The orbital fissure pass through it the oculomotor nerve, while the ophthalmic artery pass through the superior orbital fissure. The ophthalmic nerve doesn't pass through the superior orbital fissure. This is the trick. During mastectomy, the long thoracic nerve bell is very adherent to the muscle, and the color of the fascia and the fat is yellow, and the nerve is yellow. So if you are not oriented that is in this place, you might have injury it and will cause winging of the scapula. So beware of it. When you say medial trigoid, you close your mouth. So close your mouth. When you say lateral trigoid, so you open your mouth. Lateral trigoid, you are opening your mouth. Remember, the lateral trigoid is dividing the maxillary artery into 3 parts. So, the boundaries of the safe triangle for chest drain insertion is bounded by latissimus dorsi and pectoralis major and line superior to the nipple and apex of the axilla. So, the homonymous hemianopia is a lesion due to optic tract lesion. Bitemporal hemianopia, an optic chiasm lesion. The quadranopia, we have upper and lower. In case if you forgot in the exam, remember that the upper is top. So upper quadranopia is top temporal loop, while the lower is below. The lower quadranopia is parietal loop. So upper quadranopia is temporal loop lesion, while lower quadranopia is parietal loop lesion. A very famous question about the optic chiasm lesion is a bitemporal hemianopia, and very common because you are almost asked in every exam about acromegaly, which is maybe due to a pituitary tumor, and ask you bitemporal hemianopia, which is a lesion due to optic chiasm. You might be asked about the optic chiasm lesion or the lesion caused by the acromegaly lesion, bitemporal hemianopia, and you may be asked about the gland which can cause the compression over the optic chiasm, which is a pituitary gland. Hope it's clear with you. During splenectomy, division of the short gastric vessels will be must, just like ligation and cutting the splenic artery. And remember, during splenectomy, at the moment you have clamped the splenic artery, you have to give platelets. Most of the cases of osteomyelitis of the spine, there will be history of recent pelvic surgery, urinary tract infection, cutaneous sepsis, or diabetes mellitus. It's likely that hematogenous spread occurs via vertebral venous plexus, the Patson's plexus, to the spine. The most common infecting organism will be the Staph aureus, although gram-negative organism can occur in association with UTI infection. So when you find an UTI, think of gram-negative infection, but mostly it will be staph. The pain is usually worse in the recumbent position, and the patient is frequently pyrexial, will have a fever, and the TLC and the erythrocyte sedimentation rate, C-reactive protein, all will be raised. You will have the white blood count raised, the erythrocyte ESR raised, the CRB, the C-reactive protein will be raised. And blood culture computed topography and radioisotope or magnetic resonance scanning may be helpful in making the diagnosis. And of course, you know that osteomyelitis early sign doesn't appear in radiology but in MRI. Take care, there is a big difference between filon and paronychia. Paronychia occur between the tip of the nail and the cuticle, while the filon is an abscess in the compartment of the pulp. And this is usually more painful than paronychia, by the way. And never wait for fluctuation, remember. Herpetic Whitlow is caused by herpes simplex virus. It's a small clear vesicle which are seen causing the herpetic Whitlow, herpes simplex virus. Remember that the deep peroneal nerve supplies the first toe cleft, the first web space supplied by the deep peroneal nerve. Isn't it funny that the deep peroneal nerve is found in the anterior compartment? However, it only supplies the first web space innervation, while the superficial peroneal nerve found in the lateral compartment and supplies the dorsum of the foot, except for the first web space. There is much philosophy in this. You can think of it. Remember, the plantar surface of the foot, the plantar surface of the toes of the foot are supplied by the digital branch of the medial and the lateral plantar nerve. The medial plantar nerve innervates 3.5 and the lateral supplies 1.5. They also supply the skin of the dorsum of each toe proximal to the nail bed. So, fat embolism syndrome is a clinical diagnosis. Trauma in the long bone or pelvis account for 90% of the cases. The exact frequency is unknown, as the diagnosis is often missed or masked in trauma patient. However, it carries a mortality between 10 to 20% and must always be considered in your differentials. Patient present with tachycardia, tachypnea, pyrexia, reduced consciousness, and hypoxia. They may develop petechial rash or thecal rash because the P is silent on the upper chest in less than 50% of the cases. Oral mucosa or retina will develop conjunctiva as well, may develop rash as well. So, searching for fat droplet in urine blood or CSF may help in confirmation of the diagnosis. Of course, management will be mainly supportive and mainly arterial oxygenation, and surgical stabilization of the fracture reduce the risk of the occurrence from the start. The term aseptic loosening in ortho, aseptic loosening means loosening of a prosthetic joint without the involvement of bacteria. Aseptic loosening, which is loosening of the prosthetic joint without the involvement of the bacteria, occurs as a late complication affecting approximately about 5 to 10% of total hip arthroplasties, and foreign body component worn off the artificial surface and initiate inflammatory reaction involving macrophage, causing osteolysis of the surrounding bone. Patient present with pain, and if the femoral component loosens, sinking further into the femoral shaft and decrease the leg length may occur. It's important to exclude late infection as a cause of the pain, and diagnosis will be helpful by serial X-ray showing changing orientation of the component and the progressive line around the bone prosthesis interface. Treatment will be revision of the joint. Take care. Pain during the last degree of shoulder abduction is typical for osteoarthritis, particularly in presence of osteophytes in X-ray. Supraspinatus tendinitis usually present in occupations or jobs with shoulder overuse, characterized by pain and impingement during 60 to 120 degree abduction. Frozen shoulder. Frozen shoulder is common in middle-aged women, especially diabetic, and X-ray don't show any abnormality, as the main pathology is adhesive capsulitis, which can be released by arthroscopy. Aseptic arthritis still needs to be excluded where blood result can be unreliable. Then the gold standard is culture of the joint aspirate. So culture of the joint aspirate is needed, and frozen shoulder, like adhesive capsulitis, and must be differentiated from septic arthritis by joint aspirate. You can see Elsa in Frozen. It will remind you of the frozen shoulder. She is a middle-aged female. She is diabetic. Her X-ray is normal, crystal clear, because you can see her with the eyes, and she can have a global limitation of movement. So this reminds you of the frozen shoulder. Look at her poster, like the poor girl, Elsa. First friends, although posterior shoulder dislocation is less common than the anterior dislocation, but you have to keep it in mind because posterior dislocation takes place after seizure and electrocution. Anteroposterior view may not show any abnormality, and the scapulohumeral view will show the posterior dislocation. The most common tumors that send metastasis to the bone are 5: breast, lung, prostate, renal, and thyroid. The prostate cancer is most likely in gentlemen of this around 70, and prostate metastases tend to be sclerotic, osteoporotic, osteoplastic, sclerotic. And the sclerotic, although it's osteoplastic, the sclerosis of the bone will cause, yes, pathological fracture, while the thyroid renal metastases tend to be lytic, and the breast and the lung tend to be mixed between lytic and sclerotic. That's why prostate cancer, even it's osteoplastic, it's sclerotic, will cause pathological fracture. Isn't it funny that the low body weight is the risk factor for osteoporosis, not the obesity? So long-term heparin is a predisposition for osteoporosis. Gastrectomy, predisposing for osteoporosis. Osteogenesis imperfecta is predisposing for osteoporosis. Even diabetes, predisposing for osteoporosis. While obesity is not a predisposing factor. The low body weight is the risk factor for osteoporosis. So what does medicine want from us? They want us fat or thin. You will get bone disease either ways. A very old patient around 70s who have a fracture should have bisphosphonate, calcium and vitamin D supplementation in all patients. Yes, and this scan is only needed in the patient aged below 75 years. Hormone replacement therapy has been shown to reduce vertebral and non-vertebral fracture in this age. However, the risk of cardiovascular disease and the breast malignancy makes this a less favorable option to use the hormone replacement therapy at this age. So again, bisphosphonate like aldronate and calcium and vitamin D supplementation should be given to all patients age above 75-year-old for having a fracture. You have to be happy to study productively. So make yourself happy by revising your previous questions. It's normal to find the new questions or the new brainstorming ideas hardens your mind and confuses you. This is normal, but next time you will see it, you will answer the question before even reading the answers. So make yourself happy. To distinguish between the femoral hernia and the saphenous let's talk first about the elective case. There is no complication either in the femoral hernia or the saphenous. So the femoral hernia will be reducible, while the saphenous is compressible. The reducibility means when you compress over the swelling, it will be reduced and disappear and will not come back until you do some sort of straining or cuffing. While the saphenous might be compressible, means you can compress it, it will disappear, but at the moment you remove your hand, the swelling will be back again. And in straining, the femoral hernia will appear, while the saphenous it's always there. The swelling will not disappear until you lie down. The saphenous with cuff, it will give thrill on cuff, while the hernia will give expansile impulse with cuff. Thrill, not expansile impulse. There's a big difference between those two. Femoral hernia, if complicated, it will be non-reducible and doesn't give impulse with cuff, while saphenous if caused thrombophlebitis, it will be tender and inflamed. Some thrilling might be present or not, but mainly the main difference between the femoral hernia if complicated and the saphenous will be the femoral hernia will be irreducible, no cuffing impulse, and the saphenous will be always giving thrill. A teenager girl with knee pain on walking down the stairs is characteristic for chondromalacia patella. Patellar dislocation is a common cause of hemiarthrosis and may be spontaneously reduced when the leg is straightened. Remember, Behçet's disease is idiopathic avascular necrosis of the femoral epiphysis of the femoral head. It's due to impaired blood supply to the femoral head, causing bone infarction. New vessels develop and ossification occurs, and the bone either heals or subchondral fracture occur. The clinical features will be a male 4 times greater than females and age between 2 and 12-year-old. The patient will be limping with hip pain and bilateral in 20% of the patient. Weber A fracture. Weber A fracture is stable ankle injury and therefore can be managed conservatively, for example by applying an ankle boot. Weber has 3 types: Weber A, Weber B, and Weber C. Weber A below the level of the syndesmosis, Weber B fracture at the level of the syndesmosis, and Weber C above the level of the syndesmosis. Type A Weber fracture mostly undisplaced and can be managed conservatively mostly, while Weber C and Weber P, Weber C will be surgical, while Weber B according if it's stable or unstable. Direct trauma to the shoulder causing pain, swelling, and broken clavicle with the appearance of a stiff deformity. This makes us think of the acromioclavicular joint dislocation, and it's normally occurred secondary to the direct injury, as we said, to the superior aspect of the acromion. And the stiff deformity of the shoulder is very specific for the acromioclavicular dislocation direct trauma. This will lose the shoulder contour and the prominent clavicle will occur. This is the key features for acromioclavicular dislocation. Hill-Sachs lesion. The Hill-Sachs lesion occur when the cartilage surface of the humerus is in contact with the rim of the glenoid. About 50% of anterior glomerular head dislocation associated with this lesion, the Hill-Sachs lesion. Rotator cuff tear. It's often present as an acute event on the background of chronic subacromial impingement in the older patient, but can present as an avulsion injury in younger patient. Majority of rotator cuff tear are to the superior cuff supraspinatus or infraspinatus or the teres minor, though a tear to the subscapular is associated with the subcoracoid impingement. Tears present as pain, weakness, with using the muscle in question. So take care which muscle he is talking about and think of its action. Is it a rotator cuff? Yes, so it's a rotator cuff tear. Regarding the meniscal tear, the medial meniscus is most often affected. True locking of the knee joint will occur with the meniscal tear, but take care. Meniscus tear have no nerve or blood supply and thus heal is poor, and this will require arthroscopy and meniscectomy to treat the meniscal tear. It can't be treated conservatively. In the chronic setting, there is a typical little find on examination if the knee is not locked. An arthroscopic approach again may be used to treat most of the lesion. Hemiarthroplasty is offered to the older, less mobile individual compared to fracture reduction and fixation in younger patients. Remember that giant cell tumor affects the epiphysis more than any other bone tumor. Remember that Ewing sarcoma appears as onion peeling on preosteum, and it might be presenting like osteomyelitis, so don't confuse them. And remember, Ewing might be present as osteomyelitis features. Development of the hip is tested by Ortolani and Barlow. Barlow and Ortolani are a very famous test for developmental dislocation of the hip. We use intramedullary nailing for midshaft femur or even midshaft tibia fracture. It gives more stabilization. Intertrochanteric is extra capsule and mostly the blood supply will be preserved. In younger patients with the femoral neck fracture at the intracapsular level requires very fast fixation to preserve the blood supply as much as possible. You can use cannulated screws or either total hip replacement. Cannulated screws in femoral neck fracture intracapsular in young patient is a good option to try to preserve the blood supply as fast as possible. But if failed, you can use you can go with the total hip replacement, total for the younger, while the hemiarthroplasty is preserved for the limited mobility of the old age. Good day, dear great surgeon. Just make sure you are logged in your Google account and open the MOOCs through Google Chrome to open all the MOOCs.
All the mocks are kept open for all our candidates for free. If any problem came up or any obstacle, just post it or screenshot that problem to work on it. If anybody faces this problem as well, just post it in the group and let's work on it.